In the exam, you need to be able to describe all the different features of an ET tube that help it serve its function. The function of an endotracheal tube is to be a definitive airway, so it protects the airway by completely isolating it from the pharynx and the esophagus, reducing the risk of aspiration and allowing you to provide work of breathing with a ventilator. So to achieve this, it is made of pliable, inert, see-through plastic, and it has a standard 15mm connection which allows you to connect it to the ventilator. It has this radio opaque line which allows you to see it on an X-ray. It has a low pressure, high volume cuff that forms a seal within the trachea and prevents aspiration. The end of the tube has a left facing bevel, which means that as you're intubating and you're bringing the tube in from the right hand side of the patient's mouth, it's easier to visualize the glottis because you haven't got the end of the tube blocking your view. Also notice you have this Murphy's eye, which is this second hole, and that's as a safety mechanism. It does two things. One, it means that if your distal end of the tube gets blocked here, you have this port to still deliver gas through, so it reduces the risk of the tube becoming blocked. It also means that if the airway to the right upper lobe comes off the patient's trachea, which can happen as an anatomical variation, you have a better chance of ventilating that rather than obstructing it with the wall of the tube. We have this pilot balloon with a spring-loaded one-way valve, which means that not only will it hold the pressure inside the cuff, but it allows you to assess the pressure because you can feel if the cuff is inflated or deflated. You have this black glottis line, so you know that as you're intubating, that's the point at which you need the vocal cords to sit. That tells you've put the tube in far enough. And then we also have these gradations with centimetre markings that you can measure to the teeth or the lips, and it tells you how far in you have put the tube. And finally on this one, this is what we call an ITU tube because it's got this extra port. So most ET tubes don't have this extra yellow port. This is a subglottic suction port. So if you look here, just above the cuff, there's another orifice there. And the idea is that once the cuff's inflated below the cords, on intensive care, if you've got someone intubated for quite a while, you're going to get secretions building up and trickling down the tube. But they shouldn't go beyond the cuff because that's inflated and creating a seal. So they tend to pool just above the cuff here. So this port allows you to aspirate secretions through this yellow port here. And a common follow-up question in the exam is when might you use an uncuffed tube? And the classic example is in pediatrics because the narrowest point of the airway is the cricoid cartilage rather than the glottis itself. And so if you put the tube with a cuff through the vocal cords, it may then find that it's too narrow to push that cuff any further, and then inflating the cuff may cause too much pressure and therefore cause tissue necrosis. So you put uncuffed tubes in very small children. And those are all the features of an endotracheal tube that allow it to serve its function.